All right. Welcome everyone to Preparing for a Good End. This is a program that focuses on hospice, palliative care, and end-of-life care. It is a community dementia education program of Alzheimer's San Diego. My name is Amy Abrams. I'm the Director of Education with Alzheimer's San Diego. And very pleased today to be joined by my colleague, Ellen, who's a member of our clinical services team.
Hi, everyone.
Hi, Ellen. We're so happy to have you with us. Ellen will be busy today behind the scenes, helping out in the Q&A, answering questions, and helping me during the question and answer, the verbal question and answer part of our program. So here is our agenda for today. It's lengthy, it's in depth, and I'll try to cover as much of this as I can. I do want to acknowledge this is part 2 of a 2-part series on late stage Alzheimer's and dementia. If you didn't attend the first part last week, this is a standalone program and it will make sense without having attended it. And if you did attend last week, a bit of what we're covering today will be a repeat, but not a lot. I'll go through those topics fairly quickly. So hang in there either way. And if you didn't attend our Care in the Late Stage program last week, it is available in our webinar library. You can go back and watch that recording and see what you missed. But here's what we'll be talking about today. We will talk about what to expect in the end stage of dementia, what we mean by that. I'll talk about palliative care and hospice care in some detail. We'll talk about advanced care planning and death care, sort of the things to be thinking, talking about right now, and planning for down the road. And we will talk, of course, about grief, bereavement, and resources for more information and support. I'm going to start with the difficult topic of the end stage of dementia. And before I do that, I want to just ask us all to kind of take a deep breath here, right? I'm talking to myself as much as I am talking to you. This is a hard topic for all of us, and I just want to acknowledge that, help us kind of get centered and think about how difficult today's discussion is. I know it wasn't easy for you to sign up for this webinar or to log in here today, and I thank you for being here. So we'll just ask everyone to take a deep breath. And just let whatever you're feeling right now, let it wash over you. Not that we're going to ignore it or push it aside. I want you to feel it. But we also want to just sort of acknowledge it, whatever those emotions are. If you are comfortable doing so, if you would like to, feel free to send a little message in the chat right now. And by the way, please send it to all panelists and attendees. That way we can all see your message. And just tell us why you're here. How are you feeling right now? When you think about the wave that just washed over you, the thoughts that you're thinking, the questions you have, the concerns, the fears, the feelings, what are you feeling right now? If anyone wants to share that with us, I'd love to know who's here. I don't get to see you or hear you, and it's really helpful to know how you're doing. We'll just give that a minute. Feeling uncertain, uninformed, yeah, understandable. I'm wondering how I'm going to get through it. This is all new. This is a brand new diagnosis. Yeah. Mother in late stage on hospice, wanting to understand this process better, feeling torn, divided. These are some beautiful words. I'm feeling sad, close to tears. Me too. Yeah. I want to be prepared for the future. I want to learn what's going to happen before it happens. Yeah. Thank you. My mom is 90, late stage. I'm prepping her to pass this year. Supporting someone as they're preparing to die is a real gift and a really important reason to be here. Thank you. I'm afraid. I'm not sure what to expect. It seems like it's taking a long time. Boy, I understand that. Yeah. Yes. This is an ambiguous type of loss that we're all experiencing. Absolutely. Right. This is unlike other types of illness and other types of loss. Yeah. Through this entire journey, try to stay a step ahead and be ready for what comes next. Wonderful. I admire that deeply. And that is our goal here today. Thank you all. Please, I'm going to keep moving, but please feel free to, I'll be keeping an eye on the chat as we go along here. So feel free to write in any additional notes if you'd like to as we go along. And thank you for opening up a little bit and sharing some of that with me. I appreciate that. So let's see if I can get, here we go. So there's just a lot of words and language that gets thrown around regarding the end of life. And I just want to be clear, when we talk about hospice care and palliative care, end of life care, death care, you'll see these terms sort of used interchangeably. They mean different things. Chronic disease versus acute disease or illness. A complex illness, many different types of illness, or an illness that affects lots of different systems versus a serious illness. And how is serious different from life-limiting versus terminal, right? These are all different terms. They all mean different things. At the end of the day, what's important to recognize is that whatever term you're reading, hearing, seeing in the materials or hearing from the hospice provider, for example, what matters to our discussion here is that dementia is a fatal illness. Dementia meets all of this criteria, right? It is chronic. At times, people are experiencing acute symptoms. It is complex. It makes caring for other health conditions more difficult, more complicated. It is serious and life-limiting. And it is, in fact, a terminal illness. And that is information, I think, that our healthcare providers don't always share with us. And it is hard to talk about, it's hard to hear, but it is important that we be really clear about that, right? When we talk about the end stage of dementia, we are talking about the end of usually what was a pretty long journey for a lot of folks. Typically, if you've attended classes with us, you've seen this, this graph before. We talk about the early, middle, and late stages of dementia as the phases of the disease wherein symptoms are mild, moderate, and severe, right? In the late stage of the disease, the person is requiring assistance with all of the basic tasks of daily life. And the late stage is usually, but not always, the shortest stage of the disease. What exactly we can expect in terms of symptoms, the severity of symptoms all along the way is pretty unpredictable and pretty varied person to person. No two people will experience the same type of symptoms or the same progression of symptoms. But the end stage for most people looks pretty similar. And I'm not talking just about the end stage of Alzheimer's or dementia, right? The end stage of life, the end stage of a terminal illness. There are some things that we can expect to see. So why is it that Alzheimer's and dementia are fatal and terminal illnesses? These are diseases of the brain, which is controlling every essential function in the body. And so when there is disease in the regions in the back of the brain, the cerebellum and the brainstem, these are usually the parts of the brain that are not heavily impacted by the disease. Whatever type of dementia the person has, they usually remain pretty healthy and pretty functional until the person reaches that late stage of the disease. And in the end stage, there's quite a lot of disease in these regions of the brain. And so the person has very little in the way of muscle control, very little language capability, difficulty with swallowing and chewing. Difficulty regulating one's own body temperature, being too warm or frequently being too cold, having a hard time with digestion, severely disrupted sleep cycles, and eventually, right, the brainstem is the part of the brain that's sending signals to all of the essential organs. And eventually, when there's damage in the brainstem, at the end stage, the heart and lung function stops. So it's important to recognize that people can die with dementia in a variety of ways. It could be pneumonia, it could be an infection, their heart could stop, they could have congestive heart failure or experience cardiac arrest. There's many reasons outside of the Alzheimer's or dementia that might cause the person's death, but it is a complex illness. It is usually a contributing factor. But people can and do absolutely die from Alzheimer's disease and dementia as well, because again, the brain is the control center, and systems effectively shut down as a result of the brain damage. So all of that is hard to talk about. It's a lot to take in. It is very important, as we covered in our last program about care in the late stage, it is important to recognize what does remain, however. Right? People do retain a general sense of place and the people who are around them, how it feels to be there, good, bad, or otherwise. People can respond to sounds, touch, the tone of our voice, the warmth or lack thereof that they detect in the interactions with the people around them. And certainly people continue to respond to nonverbal sensory stimulation. So just very, very briefly here today, we'll talk a little bit about staying connected at the end of life. It's challenging. It takes a lot of effort and a lot of energy. So I suggest first we just start by, kind of again, taking that deep breath and managing your own expectations about how this is going to go. It might not go the way that you want to. These visits might be frustrating. They might be sad. I suggest keeping your visits as short as possible. And, you might live with the person. So I'm talking about the time you spend at the bedside, right? Make them frequent if you can, but keep them short, right? In order to make them reasonable for both of you. Just a couple of tips here. If possible, using somebody's name instead of your term of endearment for them, right? Calling them Amy rather than sweetie, right? Or Amy rather than mom, or Joe rather than dad, right? That might be awkward, but in fact, a lot of people, what we see is that a lot of folks they're able to respond better when they hear their own name rather than those terms of endearment or those sort of relationship oriented terms. So give that a try if it feels comfortable for you. Be okay with silence, right? Know that you may be having a visit, having an interaction wherein you're going to get very little in the way of response. It doesn't mean they don't know that you're there. It doesn't mean they're not benefiting from the time or from the interaction, but just allow them to sit quietly and not respond, to keep their eyes closed. Right? It's awkward, it's uncomfortable, and it gets to start to feel like you're kind of running a private monologue at times. I understand that. So you might want to do things like incorporating music, right? Playing music together and singing along or humming or just listening quietly together. Using the other senses, right? Foods or lotions or oils that smell good. Putting something soft in their hand so they can, appreciate the softness of fabric or an animal that's fuzzy maybe, right? Whatever that might be. Think about other ways you can engage their senses if your visits are trying and challenging for you. Look for those little responses. You might not get a lot of verbal interaction. You might not get any verbal interaction, but might you see a little twitch, right, of their lips, of their cheek, a little wink of their eye, or a little flutter of the eyelids. Look for those minor little responses and know that they matter, right? Know that they could be the person trying to communicate something to you, or it could just be them responding to you, reacting. Right? Lots of different ways we can interpret that, and try to be creative, right? Patient, right? Okay, this attempt didn't really work that well. I'm going to take a deep breath, walk away, and try again another time. These days, a lot of people are having to do these end stage connections in difficult ways over the phone, over video conferencing, by sending notes that somebody else reads aloud, right? So I do recognize the challenges and the obstacles of our current environment and trying to stay connected at the end, but do your best, right? So what to expect at the end of life? It is not uncommon for people to have little to no mobility, to be sleeping most of the day, very common. We'll see that in the sort of transition to the end of life. We see less movement, we see less talking or changed communications and more sleeping. And at the end of life, sleep is most of the day, if not all of the day. Very limited communication. They may be minimally responsive. So even those little twitches may dwindle in the end of life. I am talking here about the period that is sometimes referred to as active death, right? We're somewhere between that transition and the time that the person has died. It's the act of dying, sometimes referred to as active death or the end of life. Right, so minimal responsiveness. There will not be any more eating, taking in of food or liquids at this stage. Not uncommon for extremities to get cold, for skin color in the face or elsewhere on the body to change, either to become pale or to mottle, to become kind of red and blotchy. And then, of course, we will notice changes in breathing and an eventual stop to the breathing. Now, I am describing here what active death, the end of life, looks like in a sort of typical, if we can use that term, somebody who is dying of dementia, right, of the brain disorder. Now, there are other ways, that a person, other reasons that a person may be dying. And so, of course, if it's a cardiovascular event, other illnesses taking over, then the death may look different. But these are sort of generally the things that we can expect to see. So again, I'll just ask that we kind of pause and recognize, right, whatever you're feeling here. Grief is not something we only feel when the person has died, right? We're probably feeling grief all along the way. Someone referred earlier in the chat to the phenomenon that we call ambiguous loss, right? And that means you're grieving now. The person is still here, but you are already grieving the things that you have lost, the function that they've lost, the memories that you've lost together, right? We don't only experience the grief after the person has died. You're likely feeling some of that now. So just again, kind of remember, whatever it is that's washing over you, we need you to have a life preserver here, right? In the form of your own natural support system from us at Alzheimer San Diego, or formal supports, things like hospice and palliative care, which we'll talk about next here. So palliative care. This is a nice graphic that I picked right up from Vitas Healthcare, a large provider of hospice in our region here in San Diego County, but elsewhere around the country as well. I really like this visual depiction of the ways that palliative services and hospice services differ, but what they have in common. So let's start there, just sort of looking at what they both provide is comfort care. They reduce stress. They offer complex symptom relief related to serious illness. Again, dementia meets that criteria. And they provide physical and psychosocial relief. So I won't focus on the differences now here, because we'll be talking about those as we go along. So palliative care services, generally speaking, I'm starting with palliative because it's a sort of, it's a broader type of care that is available to more people than hospice services, but it is pretty poorly understood and not very widely used still here in the US. So I'm starting there. It's medical care. It's specialized medical care that focuses on addressing suffering, addressing pain. That could be physical, could be spiritual, emotional, psychological. Pain of any kind is what palliative care is designed to address, right? The pain, symptoms, and stress of serious illness. A lot of the language that I have here in this program today comes to us from the National Hospice and Palliative Care Organization, and their website I have provided for you in a link at the end of the program, so you can read all of this in much more detail, but I've summarized a lot of their very helpful language here. So palliative care is mostly medication, but it's other types of therapies as well. And it is usually provided in conjunction with curative care. Now, Alzheimer's and dementia is different because, of course, we don't have curative care as we do for things like cancers, right? And other illnesses where palliative care may be used. But that is to say, it's different from hospice in that you don't have to be no longer sort of seeking treatment. You can use palliative care services at any stage of any type of a serious illness, at any age. There are no age requirements or limitations on pain, of course. And regardless of the life expectancy or prognosis related to the terminal illness, it is an appropriate type of care. It is not time limited, unlike hospice, which is provided for in sort of short periods of time, which we'll talk about here in a bit. And it can be provided in just about any type of care setting. So palliative care services are about pain and symptom management. You get in-person visits. These days, of course, they're doing lots of telephonic visits, but it is usually in-person care that is provided, in the hospital, at the bedside, in the home, in a nursing home, wherever the person is. It provides social support to help people kind of navigate their treatment options for people who are using palliative care services related to an illness that has treatment options, of course. It provides advanced care planning services. You get sort of assistance with documents and navigating the complex road of advanced care planning, and of course, referral to appropriate community resources. So it is an interdisciplinary team, similar to the folks who provide our hospice services. A physician, there's usually a dedicated nurse, but also a team of other types of nurses involved in palliative care. The social worker who provides that navigation and help with advanced care planning and referral to community resources. Chaplaincy services for spiritual care, for addressing spiritual pain, and volunteers of a variety of stripes who provide supportive services around pain and symptom management. How do you pay for palliative care services? If you are a Medicare recipient, it is covered through Medicare Part B, but it is subject to co-payment. So you do need to, as whoever your payer is, you want to be familiar with your benefits and co-payments that might be associated with it. It is covered by some Medicaid programs, including ours here in California, Medi-Cal. There are limitations, however. There are certain restrictions around payments, and some co-payments are required, both with Medicaid providers and with private insurers. So again, widely covered, but you do want to be aware upfront of what your benefits are and what co-payments might be associated with that. Some treatments, some medications, for example, may not be covered by your specific plan. So get familiar with your own, either your Medicare benefits or your other insurance benefits. How do you access palliative care services? It is referred to like any other type of specialty care. So if you're in a hospital, all hospitals have palliative care staff. Some of them have palliative doctors on staff. Palliative care is something that is provided basically everywhere, and you just have to ask for it. So referrals work for palliative care the same way they work for other types of specialists in your specific insurance environment. So if it's Medicare, you can pretty much just ask for it, self-refer. If it's a private health insurance policy, you'll need to seek that referral from a primary care provider. There might be some questions here about how is it if there is no treatment, right? If you know, Alzheimer's doesn't cause physical pain in a direct way that we know of, what are we talking about in terms of palliative care? It is usually used in late stage dementia to address emotional pain. When a person with dementia in the late stages, or frankly, any stage, is experiencing severe anxiety, severe sleep disturbance, for example, dramatic behavioral disturbances that are causing them emotional, psychological, spiritual pain, palliative care referral can be appropriate. So just to connect those dots, if that wasn't clear. All of these services are provided in collaboration with one's primary care provider. So it doesn't replace your regular doctor. It's another type of specialty care that is provided. It's kind of layered on top of and around other primary care or neurology or psychiatry services that the person may already be receiving. And again, it can be provided in any number of licensed healthcare settings or in the home in the form of home healthcare. Okay, so if you have questions about that, we are going to be pausing for questions. I didn't say that at the beginning. I apologize. We will be pausing to take a few questions a bit later in the program. So I'm going to move on to hospice care, but if you've got questions about palliative care, feel free. You don't have to wait until then. Go ahead and write those into the Q&A, and we'll address those as we can. Let's talk for a moment here about hospice. Hospice services are probably better understood than palliative care services, but still not widely known, not widely used. They are heavily misunderstood. So the National Hospice and Palliative Care Organization indicates that in 2016, I'm reading the statistic here, the average length of time that people received hospice care in the US that year was 71 days, which sounds like kind of a lot, but about half, a little over 40% of all hospice patients received care for only 14 days or less. So many people will use hospice services for a long period of time, but the majority of people don't reach out, request that hospice referral, and get those services in place until the very end of a terminal illness. And that's something I really want to address and help you recognize that these services can and should be used long before we've reached that sort of that active dying part of the terminal illness. So what hospice is not a place, as is commonly thought of. There are places called hospices where hospice care is provided, but hospice is a type of care. It's a concept of care, doesn't necessarily refer to a physical place. And it is a type of palliative care. It's a very specific type of palliative care that focuses on the pain, symptoms, and stress of terminal illnesses. So that's what makes it different from general palliative care services. An illness is defined as a terminal illness, as being in sort of hospice eligibility of that terminal illness, according to Medicare, right? The folks that pay for hospice services primarily, when the person's life expectancy is 6 months or less, given a sort of normal trajectory or progression of the disease that they have. So, of course, many people live longer than that 6-month period. All that means is that in order for hospice services to be initiated and approved and paid for by Medicare, a doctor would have to reasonably be able to say, yes, I think that given the natural progression of this person's Alzheimer's or whatever form of dementia they have, I think they're in the late stage here, and I would expect that they will pass away within the next 6 months. That's the requirement. The requirement is not that they actually die within that 6-month period. Right. So hospice is care not just for the patient, but for their family or their support system, right? Whoever that may be, whoever they call their family. And those needs are provided, again, by an interdisciplinary team. It's not just one specific person providing hospice care. It is a type of palliative care. It is a Medicare benefit and is covered by, well, we'll talk more about the payment here in a moment, but it is usually covered pretty extensively by one's Medicare benefit. Differently from palliative care, it is time limited. It is provided initially for when a person is approved. It is provided for up to 6 months while the person is alive, but absolutely can be extended. A person just needs to be recertified, meaning that a physician needs to confirm that, yes, they are still eligible for hospice services, and then they can continue. But some people do transition off of hospice. The care that they get makes them feel better and function better, and then they're no longer eligible. So they transition off, but you can restart anytime. It doesn't just end when the person dies either. It can continue. The bereavement support that is available to family can continue for up to 13 months after the person has died. A very important benefit to be aware of, and a really good reason to bring hospice services in if you aren't otherwise inclined to do so. And like palliative care, hospice can be provided just about anywhere in any type of a care setting. So the types of services that are generally provided are listed here for you. Pain and symptom management, 24-hour on-call service is available. There's nurses on call to handle inquiries or to make visits as needed after hours. In-person nursing, social work, chaplaincy visits at the home or wherever the person is. Medical equipment, the rental of things like hospital beds and shower chairs and other types of equipment that will make life more comfortable to address the pain and symptoms that the person is experiencing. Those are generally covered by the hospice benefit. All of the medications and equipment and care that a person needs related to the terminal illness. Every medication that they take will not necessarily be covered because, you know, we are no longer, the assumption here is that we're no longer seeking cure for this or, you know, any other condition. So related medications to the Alzheimer's diagnosis, for example, medications and treatments that address behavioral disturbance, memory, cognition, or that keep the person comfortable when they are no longer able to complete their activities of daily living on their own. That type of equipment, medication, and support is what's covered. So not necessarily everything that the person uses. There are different types of care. There's inpatient care. There's what's called continuous care in the home when the person's symptoms are severe. Spiritual care is always made available through chaplaincy services, and it is multi-denominational, I should say. So spiritual care is usually available to folks who want it and need it. Volunteer services, again, we see an array of different types of volunteer visits, bedside vigils that volunteers can make. People come and bring animals to do animal therapy. All sorts of different types of volunteer services are out there. And then, of course, those very important bereavement and counseling services. So that can mean, you know, sort of right there on the spot conversations in the moment with the person who has the terminal illness or with their friends and family, right? Teaching about caregiving and coping with grief, or it can be sort of formal counseling services outside of the care setting. So bereavement and counseling services encompasses a lot of different things. So there are 4 levels of care. And, you know, when you initiate hospice services, you will have an in-depth admissions meeting where they will go through all of this in great detail with you. But for your general familiarity, the 4 levels of care are routine, wherein the person is just receiving, you know, maybe weekly visits from nurses. It's not intense. It's not an intense provision of medical care. Sometimes hospice is provided on an inpatient basis. That could be because symptoms are hard to manage at home, and they need to get the person inpatient and under, constant surveillance or heavier medication that can be administered at home, for example. So sometimes hospice is provided on an inpatient basis, either in a hospital setting or at a physical hospice location. Continuous hospice care refers to when it is authorized at the very end of life in most cases, or if the person is experiencing sort of a dramatic increase in the severity of their symptoms. Continuous care in the home, 24-hour care at the bedside can be provided by the hospice. This is not generally available on an ongoing basis, but it is sort of the most intense of the levels of care. And then, of course, there's respite. Sometimes short-term inpatient care is available when the pain or symptoms can't be managed at home, or when the caregiver just absolutely needs a break. They need a respite time. You cannot be doing this even with hospice support, even with palliative care. If you are in need of respite, sometimes the hospice can move the person into an inpatient setting for a short time in order to provide respite. The benefits of hospice are frankly hard to calculate, but in summary, keeping the person as comfortable as possible, a lot more attention than in terms of medical care than a person can get without hospice services. And one of the primary benefits is the reduction of hospitalizations, right? If a person has a fall, if a person has an infection, you don't have to run to the emergency department for every incident. The hospice team can come to you, which is hard to state the value of reduced hospitalizations for a person with dementia. So who are the folks who provide hospice care? I'll actually start on the right side of that screen. There are many different types of hospice organizations, state licensed and Medicare certified. Most of them here in San Diego County are, but there are also non-Medicare certified providers of hospice services, and the VA offers hospice services as well. Hospice is an interdisciplinary service, so the physician is sort of the core of it. And this is an important sort of point of discussion and negotiation right at the beginning. And the hospice will help you with this, but sort of figuring out who's going to be the hospice doctor, right? It could be your primary care physician. You can stick with your own primary care physician as long as they agree to that. Or you can work with the hospice physicians, or the medical director of the hospice is sometimes called in for consultation as well. So just be aware that going on hospice doesn't necessarily mean giving up your own primary care physician. Often they will continue to be involved in the hospice care, but not all primary care physicians can or will do that. So there's going to be a physician of some kind overseeing the person's care, but most of what is provided is done through nurses, a team of nurses providing that hands-on care, most of those visits and the oversight of medications, that type of thing. Licensed therapists can be brought in if things like speech therapy, occupational or physical therapy will alleviate pain. If they provide comfort, they can be, we're not doing PT with the goal of getting better or getting stronger, for example. Remember, hospice services are not curative or treatment, but if they are services that make the person more comfortable, they absolutely can be provided. Of course, the social work services are central and essential in the hospice interdisciplinary team, as well as the chaplains and the volunteers. So you see a lot of overlap here with the palliative care services. So hospice services are provided anywhere that the person calls home, right? So it can be in a hospital, it can be in a care facility, and it can be in a private home. Boarding care homes, assisted living, memory care communities absolutely can have hospice providers on site. Most of them, however, have limits to the number of people who can be on hospice at any time in their building. So you need to talk that through with the administrator of the building, just to make sure that they've got the capacity. So who pays for hospice? It's pretty straightforward. For the most part, Medicare, Medicaid, and private insurances are going to cover all or most of the expenses of hospice. But again, do be aware that not every medication, not every bit of treatment or equipment is going to be covered, because it has to be directly related to the terminal illness. So keep the lines of communication open so that you know what you will and won't be billed or required to make a co-payment for. And a final point on that is to remember, while hospice is an amazing benefit, it is for medical care. It is not long-term care. So if you're living in a care facility, for example, and receiving hospice, hospice doesn't take over and pay for all of that. It's covering the medical care. You are still responsible for rent or room or board or meals, all of the other expenses related to long-term care. So how to access the hospice services? First of all, just don't wait for someone else to bring it up. I think this is a topic that a lot of us as individual people are uncomfortable bringing up and talking about. Is it time? But remember, it's hard for doctors to bring this up too. There are many physicians who are terrific advocates for palliative and hospice care services. But it's not uncommon for doctors to shy away from talking about hospice care for understandable reasons, right? They're not trained in it. It's uncomfortable. For a lot of doctors, it feels like a bit of a failure, right? That we're not gonna fight this anymore. So doctors are humans. And so please don't wait for someone else to bring this up. You can bring it up. If your primary care, if you feel it's time and you're not getting the referral, you're not getting the response that you need, you can contact a hospice provider directly and say, I'm interested in hospice services for my loved one or for myself, if the person is able to negotiate that for themselves. And then the hospice can take it upon themselves to seek out that referral. So you can initiate this. There will be an admissions process, an admissions visit, and generally it just takes a pretty short time. 1 to 2 days is standard to get hospice services going once you reach out, once you get the admissions paperwork done. It can be started more quickly in emergencies at times. So, and as with palliative care, the services are provided in collaboration with other care. The hospice does kind of take over as this is now the primary provider of most of your care because you're no longer seeking care or treatment for other conditions. But again, one can maintain a relationship with outside providers. So I'll be brief about this. The VITAS healthcare website has more information about this. Whatever hospice you work with will talk with you about the hospice eligibility criteria for late stage dementia. I like to give you, kind of arm you with the information in case you're hearing from someone that people with dementia aren't eligible for hospice. This is not true, but there are some specific criteria that the hospices have to look for and use to guide them to determine somebody's eligibility. So the person needs to be, and not necessarily all of these things. These are the various types of criteria that might make a person eligible. Unable to complete their activities of daily living or without help, or unable to communicate meaningfully. And they have some specific ways of measuring that, how many words the person uses regularly, right? If it's just a small number, they call that being unable to communicate meaningfully. Having intercurrent illnesses associated with the dementia. This could be things like urinary tract infections, pneumonia that is caused by that difficulty with swallowing, for example. So if a person is having lots of hospitalizations, infections, illnesses related to their dementia, they're eligible for hospice care. Impaired nutritional status, meaning losing weight. If they've lost, I think the number is 11% or so of their body weight within the last 6-month period, I believe is the how they numerically gauge that, but basically the person is not eating and they're losing weight, or if they have other comorbid conditions that significantly impair their health and functionality. So other conditions, heart disease, severe arthritis, right? Other things that, along with the dementia, severely limit their ability to function, then they're eligible. Choosing a hospice program is a very personal decision. There are lots of providers here in San Diego County and anywhere, wherever you are in the United States. This checklist, I won't go through it in a lot of detail. It is just intended to sort of show you the types of things to be thinking about, right? What do you provide? What do your volunteers do? What can I expect in the way of how your on-call system works? Where do you have contracts in terms of nursing homes or other long-term care facilities? What can I expect from the admissions process? Lots of different things to think about. We have resources we can point you toward here at Alzheimer's San Diego, or so too does the National Hospice and Palliative Care Organization. I won't dwell on this for now, but what's really important to know is you have a choice, right? Whatever healthcare system you are in, whatever your doctor recommends, whatever the care facility where your loved one lives, for example, recommends, you have options. You are not tied if you are a member of a specific healthcare system that has a hospice. You don't have to use their hospice services. Consumers absolutely have a choice. So do look around. A list of local hospice providers is something we can provide you at Alzheimer's San Diego if you need that. So in summary, I hope that this graphic sort of makes a little more sense now to everyone, and you can see the ways that palliative care services and hospice care services differ, but also there are many similarities. Again, happy to take questions about hospice care when we break here in a few moments. But first, I want to talk about the very important topic of advanced care planning. I'll keep this brief because, again, it is a topic around which we have other education programs here at Alzheimer's San Diego, where we go into this in more depth. But what advanced care planning is all about is, the discussions and the preparations that we can make now to think about the types of emergency care, medical care, long-term care, or end-of-life care that the person would or would not want, right? Thinking about what types of care does my loved one wish to receive or not receive, and getting in place now, being organized and ready for that. So the key documents that we need in order to be able to follow somebody's wishes, of course, before they lost decision-making capacity, we hope that they completed a durable power of attorney to grant somebody agency for power of attorney to be able to make healthcare decisions for them. If that wasn't done, then often their family, their representative will need to seek conservatorship in order to make decisions for them. The Advanced Healthcare Directive. This is a critically important document, sometimes referred to as the living will. That's kind of old language we don't use as much anymore, but you'll still see that from time to time. This is a detailed directive that gives that person who is named as power of attorney specific instructions about what is or is not wanted in the way of important kind of end-of-life healthcare decisions. I'll give you some examples of what I mean by that here in a moment. You'll probably want to have HIPAA waivers or other institution-specific waivers in place so that you can be sure you're going to be able to give and receive information freely. And then the really important POST form. Again, another topic I'll go into in some detail here in a moment. Those are the key documents that we refer to when we're talking about engaging in advanced care planning. I provided for you here a couple of really helpful websites that provide some tools. Some of these are items that you pay for, like the 5 Wishes Advanced is a detailed advanced healthcare directive. It's just a few dollars, but there is a fee associated with it. But then you can download it, and it provides a very detailed set of prompts for the advanced healthcare directive. Go Wish is a game that you can purchase to engage in conversation and discussion about your beliefs and your values and your preferences with regard to end of life. And prepareforyourcare.org is just an informational site with some great, conversational and discussion prompts. So what are we really talking about when we talk about these important healthcare decisions? What's going in those detailed advanced healthcare directives? What discussions and conversations do you want to be thinking about and preparing for now? Right? Would the person want or not want these things? These are there's more, but these are the big ones that are often provided. There's like space for these things in many of the standardized forms for advanced healthcare directives. But even if there's not, we want you thinking and talking about what the person would or would not want now, so that you're not having to make this decision on your own and not having to make it in a moment of crisis, right? Having thought it through before. So would the person want CPR, right? The efforts to resuscitate someone if their heart stops. Would the person want the use of a feeding tube? There are primarily two types of feeding tubes: the nasogastric tube that goes in, through the nostrils, the NG tube, or a G tube, a gastric, or a PEG that goes right into the stomach. Feeding tubes, questions about feeding tubes come up a lot in late stage dementia because of the difficulties of chewing and swallowing that come up so much in the late stage when those regions toward the back of the brain are heavily impacted. Similarly, the use of IV hydration, which can be provided in the form of an IV hydration, or cyclist, which is like a catheter that is inserted kind of directly into the skin for people who are having a hard time taking in enough water to stay hydrated. Ventilators, of course, have taken on a larger role in end-of-life care for a lot of people lately because of this specific symptoms related to COVID-19. But the use of ventilators, would a person want or not want a ventilator used? These are decisions that it can be very hard in that moment of decision to make for another person. So we hope that you will think about them now. Recognize that all of those, the first four things on that list there, CPR, feeding tubes, artificial hydration, and ventilators, for the most part are valuable, are useful, primarily in people who are healthy, were pretty high functioning before that intervention, who, in the case of like a feeding tube or IV hydration or a ventilator, are only expected to need it for a short period of time and are generally pretty robust, right? That is not usually the case for most people with late stage dementia. That is not to say that these interventions cannot or should not be used, but do take that into account in terms of the outcomes that you can expect when using these types of, sometimes they're referred to as heroic measures, or a little more neutral term is life-sustaining treatment, right? Additionally, one can plan ahead and think about whether or not you want the use of antibiotics or things like hospitalizations. So you might not always have a choice about hospitalizations if the person lives in residential care, for example, and they're not on hospice. If they have an incident, they have a medical condition that the staff can't care for, they're going to send them to the hospital. Another reason to contemplate the use of getting hospice in place. But you can think and put into your documents ahead of time how you feel about the use of antibiotics, for example, to treat pneumonia. If the person is in the very late stages or end stage of dementia, if they develop a pneumonia, do you want that treated with antibiotic, or would you prefer comfort care? So those are the tough decisions to be thinking about. The POST form is one of the most widely used documents to facilitate those decisions and choices. This is an image of it. It is usually printed. It's recommended to be printed on this bright pink paper because emergency medical personnel and hospitals know to look for it on this bright pink paper, but it's legal on any color of paper. The post form is a voluntary form. Everybody doesn't need a post in the same way. I mean, everybody should have powers of attorney. Anybody who's 18 or older should have a durable power of attorney. Someone named as your agent should have an advanced healthcare directive. We all need these things. Post is really for people with serious illness or advanced frailty because it's about those life-sustaining treatments. It doesn't necessarily replace an advanced directive, but it will override it if there's conflict between an advanced directive and the post. So good to have them match each other and have the same information if possible. But it is usually used as kind of an adjunct to one's advanced healthcare directive. This is a standing physician's order. You fill it out and then this is either done by the patient or their designated representative. And then you bring it into the doctor's office, and posts can be discussed now with a physician, a nurse practitioner, or a physician assistant. It doesn't have to be an MD. You have a discussion about it together, and then they sign it too. You both sign it. It is then a standing medical order. It won't expire. It can be, again, overridden. Just you render this one void and create a new one. If you want to update it, you can change it anytime. You don't need lawyers involved. It doesn't cost anything aside from whatever it costs you to get the doctor's appointment. Right. So absolutely recommend that anybody sort of at or nearing the late stages of dementia have a post form in place. And finally, the important topic of caring for a person at the time of death. And so I saw in the chat, and I know from personal experience, the fear, the sort of mystery of what to expect when someone dies, and it's understandable. We all experience it, no matter how many deaths one has attended. It's different every time, and it's gonna affect you differently. It's gonna affect you in unexpected ways. There are things to fear and be uncomfortable about. I can't mitigate that as much as I wish that I could, but maybe I can help kind of prepare you for getting through it. Right? I think the most important thing to do at the time of death is just keep breathing, right? Remembering that you're going to get through this, thinking ahead of time about who your key supports are, who you need to call or have with you, or reach out to or text, whatever it might be, who's going to support you through this. Have a plan for that. Don't rely on your own instincts. Know that you're going to be in a pretty fragile state when the time comes. So have a plan and have kind of a contact list ready to go. So you don't need to call and contact and notify everyone all at once. In fact, I wouldn't recommend it. Maybe setting up kind of an information tree if that works for you. There's those key people that need to know, but they may not need to know right in this moment. So contact the people that you need support from, right? Start there. Follow any specific instructions that you have. If the person has agreed to donate their brain for research, for example, there are certain specific steps that need to be followed, people that need to be notified. So be aware of those instructions related to body, brain, or other organ donations or other disposition wishes that the person has communicated in advance. Contact the funeral home or find one if you haven't already located one, or the funeral service, but do be aware the body does not need to be swept away and removed immediately. Right? We're not gonna catch any diseases or get sick or contaminate anyone or anything by letting the person remain with us for a little while longer. Right? So if you want the person to stay at home with you for a few more hours, a few more days, even. In many cases, they can. If they died in the hospital, they don't necessarily have to get immediately whisked away to the mortuary, right? Talk to the funeral service about bringing the person back home if you want to. Home funerals, at-home rituals can be very healing for a lot of people. It's not what everyone wants to do. I just want to make sure that you know that it's an option, right? We have a lot of fear about death and about dead people in our culture, and they don't have to be removed immediately for any type of health or public health reason. Those are cultural in basis. So be aware of that. After the person has died, there is a lot that needs to be done, but this does not all need to be done right away. Often people, just sort of rush into doing mode because they need to, right? It's kind of a coping strategy. Totally get that, but don't feel like all of these things have to happen, within 24 hours of the person dying. But these are things that need to be done. So you might want to think now about who can help you with these things. Can you divide some responsibilities, assign people to help you with some of this, if that's possible and necessary? We do have a nice comprehensive checklist for steps to follow after a death that our social workers can send to you if you need that. So, but here are sort of some of the key things, right? Making sure that the attorney who's got things like wills and trusts has been notified, banks, insurance providers, the Social Security office, any other key contacts specific to the person. You are going to want to get that death certificate either from the funeral director, or you can get it directly from the county. But do be aware it's there are sometimes lately there are some delays related to getting death certificates, but you want to round that up as quickly as possible. Find all those important documents right away so that you've got Social Security card, marriage, birth certificates, other relevant death certificates if you need them, military discharge papers, wills, trusts, a comprehensive list of the person's property, accounts, assets, and a recent tax return. These are what are recommended to gather if you can. This is a lot, and I want to make sure you also know there are professionals out there who can help with this if this is sounding like a lot. There are folks called death midwives, sometimes called death doulas. They are paid privately, and they're not volunteers, but they can help people with all of these difficult steps, either working with you in advance of the death to prepare for those grief rituals, those after death rituals, getting all that paperwork, getting all of that in place and gathered in advance, or they can be called upon at the time of death to come in and coordinate all of those sort of post-death things that need to happen. A death doula, I've included a screenshot of an article from the San Diego Union Tribune. It was published a couple of years ago about what death doulas are all about. You can find them online. We have some here in San Diego County, and they're available in other parts of the country as well. And they attend to both sort of physical, practical matters, paperwork, and all of those types of things, burials and disposition of remains, but they also attend to the dying person and their loved ones' spiritual needs as well. You may have questions about what here in California is called the California End of Life Options Act, or what is frequently referred to as medical aid in dying. I just want to start by saying people with late stage dementia are not eligible for the use of medical aid in dying services. So this is a legal option here in California and many other states for terminally ill people who have 6 months or less to live, who want to die on their own terms. Anyone who's got a terminal illness and decisional capacity who can ask for it, you have to be able to verbally ask for it, make the request, and self-administer the lethal medication, can request what's called medical aid in dying. This is not suitable for people with late-stage dementia because of those requirements. If you're within 6 months or less of a terminal diagnosis of dementia, you do not have decisional capacity. You would not be able to make that request and self-administer the medication. So there are a couple of countries in Europe where medical aid in dying is possible for people with late stage dementia, but this is not available in the United States today. This is a nice quote, I think, for a nice explanation of what medical aid in dying is not, from a local physician named Bob Uslander with Integrated MD Care. I took this right from his website, and I think it's a nice explanation. It is not assisted suicide, physician-assisted suicide, or euthanasia. The distinction between medical aid in dying and these other practices is that the person taking the medication always remains in complete control of not only the taking of the medication, medication, the decision and the ingestion of the medicine. Right. So that's the primary reason this is not something that is available in late stage dementia. So, Ellen, we have a few moments here for some questions. Are there any that have come in that we can talk about?
Yes, I have 3 of them. Hold on, and I will pull them up.
Great.
I also want to take a moment to mention that as this comes to a close, we tend to get a lot of questions. I will put in the follow-up form. Amy will talk about it. So if you don't get your question answered right now, we will be in touch.
Thank you for saying that, Ellen. I'm sorry I didn't mention it sooner, but yes, Ellen will be putting out a link in the chat that will take you to a form that you can fill out to request to have a social worker reach out and answer any individual questions that you have. Thanks for saying that.
Sure. Somebody said hospice told them they were not approved for COVID vaccine yet. And she wondered, does someone on hospice really need the vaccine?
Oh, gosh, that's a really interesting question. Well, the first part of that is that if a person who is hospice eligible right now is certainly eligible for the vaccine, especially if it's late stage dementia, that is under the new criteria that was released on Monday of this week, they would definitely be eligible. But whether or not they actually need it is a whole other question. Actually, it's a very personal question. It kind of goes along with those other topics that we covered before, the use of antibiotics or CPR or feeding tubes. I think you could sort of put COVID vaccination into that same category. Certainly, we don't want someone with late stage dementia to catch COVID. And if they are potentially going to have exposure to it, I don't see any reason why we wouldn't want to have them vaccinated. But I should say, I don't see there's any reason that they should be rendered ineligible for it because they have late stage dementia. But that's a very kind of personal family or individual decision. Yeah, great question.
Yeah, it really was.
Mm-hmm.
What exactly do they do under palliative care for emotional pain, behavior disturbances, and sleep?
Good question. Usually we're talking about medication, right? It's palliative care services generally, but specifically in behavioral symptom management in late stage dementia is usually about the administration of sedatives, right? Medications that will ease anxiety or depression symptoms. But it could also be other interventions that help a person sleep if their sleep is severely disturbed. I'm trying to think of an example of something that would not be a medication a medication that might be recommended, and that's honestly really all that's coming to mind. We're not talking about snowing the person with medications that will knock them out, right? We're just talking about being able to use palliative care medicine specifically to address anxiety, depression, agitation. A lot of the times the combativeness and agitation in late stage dementia can be addressed through the use of anticonvulsives. Strangely, they're pretty effective in addressing aggressive behavior in people with dementia. So yeah, that's usually what it is.
2 more questions. One, you were talking about short visits earlier in the presentation, and somebody asked, how does that work if you live at home, and why are short visits recommended?
Yeah, it's kind of strange. If you do live with the person, you can't restrict, you can't limit the amount of time that you're physically there. So thank you for the opportunity to clarify that. What I'm referring to is the intensive time that you sit engaged in one-on-one communicating and connecting with the person, right? You can be in the house together all day long without ever directly talking to each other or communicating with each other. When I say visits in this context, what I would really mean is sitting down next to them at the table, at the couch, at the bedside, wherever they are, holding hands, talking, playing music together, doing those activities and doing that sharing together. That's really focused on them, keeping those interactions short. Maybe interactions is a better word for people who live together than visits. Yeah.
Yeah. One last question that will really answer for a lot of people.
Okay.
And that is people who rally and graduate from hospice.
Yes.
And, people sometimes feel a little bit offended, how can Medicare take this great hospice support away?
Yes.
So addressing that
Yes.
topic, people who don't pass and are
right. Sometimes we'll refer to this, it's kind of cheeky, but we'll refer to it as graduating from hospice, right? You made it out on the other side because you rallied, right? We use the word rally in a couple of different contexts, but the hospice services paradoxically made the person feel better and do better, and to such an extent that they're no longer, they regain weight, right? They're no longer getting all those infections and hospitalizations. And so they don't meet criteria and can't be recertified. A very frustrating situation. Work closely with that doctor to try to get that referral back in place as soon as possible. In the interim, you may very well be able to access palliative care services, because if the person is no longer meeting hospice criteria, but still has, dementia symptoms that would benefit from more intensive medication or other types of therapies, you might be able to bring in palliative care services. But yes, this is a common frustration. I would say it's not really common in late stage dementia for someone to graduate or to not get recertified, but it absolutely happens. They're sometimes referred to as death rallies, right? Just the person seemed really close to death and then they just sort of really kind of come back to life. They're energetic again. If that lasts long enough, it may very well happen. So just have your support system in place, right? Know that you're still going to, even if they're not on hospice anymore, you need the respite, you need the support group, the people that you can talk to. So have kind of your backup team in place in case that happens. But it's not really common in dementia specifically.
That's great. Thank you so much, Amy. I'm going to go back to answering questions.
Okay, great. And thank you, Ellen. And thank you all for your great questions. And as Ellen said, there may be questions that are coming up in the final bit of the program here. If Ellen isn't able to answer them, and we can't address every question usually, please do reach out, and a member of our clinical services team would be happy to follow up with you individually about your situation. So just follow that link that I can see has already gone out in the chat, and we'll put it out there again too, and we'll have someone reach out to you. So let's talk for a moment about grief and bereavement first, just kind of explain those terms. They're used interchangeably, but they do mean different things. Bereavement is the word that's used to describe the period of time around a loss, right? When the grief is being experienced and the person is in mourning. Bereavement happens after the person has died. There is no standard of time, that bereavement happens. It's just a word that we use to describe this phase of a person's life when they are bereaved. Grief also has no timeline and is a person's individual reaction to a loss. Grief happens, as we've described, at every stage of the game here when it comes to progressive and chronic conditions like Alzheimer's and dementia, where the person is experiencing functional loss along the way. They're experiencing grief, right? As they are losing function and ability, and you are experiencing grief as sort of you reach every new kind of milestone or phase or stage of the disease. So grief also has no boundaries, has no timeline. It's very personal, right? And people experience it in lots of different ways. It usually looks like sadness, right? Sorrow, depressive type of symptoms, but not always. Sometimes grief is anger. Sometimes people feel envy. Sometimes people feel completely numb and indifferent, right? People have a whole host of different reactions. So your grief is something we really want you to be attuned to. Again, it occurs at every stage of the disease. It is not linear. And we've kind of let go of the idea that people move through the phases of grief. It's more like this sort of constant churning, which is why I like this water metaphor, right? We're kind of constantly churning in grief. And, we may never reach something called closure, which we used to really strive for, right? Every person's experience is going to be really different. And you might feel like you're kind of getting a handle on things, and then things shift and a new wave approaches. In my experience, the first year of bereavement is, I don't want to say, I'm not sure, I'm not finding the right language here. The second year, let me start there. The second year is surprisingly difficult for a lot of people. So I just kind of want to prepare folks for that. It's not to say the first year is easy, but you sort of get through all of these important landmarks. And then I think, anniversaries of things and memories and loss, and you get through all the work that has to happen after the person has died. And then I think a lot of people think they're kind of going to be over it after the first year. And then the second year really, really takes their breath away. So that is to say, just be prepared for a long journey and use those supports that you have. Reach out for new ones if you don't already have them. The ways that we grieve are totally personal, and they're influenced by so many different things, right? Who we are, our own sort of emotional and psychological construction and well-being, how we're wired, the relationship we had to the person. If you had a complicated and difficult relationship, you'll have a very different type of grief than if you had a very loving and warm relationship. And then, of course, there's our culture, our grieving rituals, whether or not we are, able to grieve very publicly and do things that feel good and bring us connected to community, or if we would rather, we're more comfortable grieving in private. Our personal beliefs about what happens after death influence how we grieve as well. Right, where you think that person went, or is doing, or what happened to their soul or their spirit, right? All of that is going to influence the way that you grieve. So that is to say, don't let anybody tell you that you're doing it wrong. Right? Whatever you're feeling is what you're feeling, and there's that concept of ambiguous loss. This was a term coined by a psychologist named Pauline Boss, who notably just lost her husband within the last year during this pandemic, and it had been a dementia caregiver, but coined this term long before any of that. Ambiguous loss, when somebody is both here and not here. Right. So that I think that's very apt and very appropriate in the particular type of grief that we experience around the loss of someone with dementia. Also important to recognize, wherever your person is in their stage and their progression of this illness, they are grieving too, whether they're in touch with it or not, right? They are experiencing their own types of grief as their life is changing, as their abilities are changing. And like us, their grief can occur at every stage. It is not linear. It's churning and whirling and swirling all around them, influenced by all of those same personal and cultural and social factors. If you can see that your loved one is experiencing fear or anxiety around death, around their own decline, right? Please address that, right? You can address it personally through your own interactions and those visits, right? Bringing them items that provide comfort, praying or breathing or meditating together, right? Doing things that are calming and centering, providing spiritual support. Again, palliative or hospice services can be very helpful in bringing in spiritual support, but you may know how to do this, right? In ways that are appropriate for your person. And don't hesitate to seek out medical intervention, right? Medications that can help slow down really someone who's really struggling for breath because they're feeling anxious. There are medications that can help at any stage, but especially in the late stage of dementia. So coping with grief, this is really kind of in summary here, a wrap up. There is no universal experience. There is no timeline. So let it go and let go of other people's expectations of how you're going to do this as well. And acknowledge that you aren't the only one who lost this person, right? Other people in their community may be grieving as well. So it's not your job to fix their grief, but just acknowledge it and know that other people are grieving along with you and maybe doing it in ways that are wildly different from how you do it. So find the support you need and know if your grief is, as you would judge it, it's persistent. It is not going away in the way that you want or expect for it to. If your grief is complicated, right? Maybe if the person did not have a good death, we can do the best we can. And sometimes the death will still be stressful and traumatic. This can produce complicated grief, and it's really important that you reach out for professional support if you are experiencing that. Getting support for talking to other people, especially talking to children about the loss of this person can be really helpful. So where do you go for that type of support? So here's, again, a reminder, we will be sending these slides out to everyone. So you don't need to quick write down or visit all of these websites. You're going to get this, but these are different informational websites where you can find out information about hospice and palliative care, both here in California, but also nationwide. Medicare has a hospice compare tool on their website. So if you're looking at different hospices in your area, you can compare them. The Coalition for Compassionate Care of California has a terrific kind of database of information, documents, decision-making tools, explainers about different end-of-life care options, medical aid in dying, all sorts of resources there. And then Post is where CaliforniaPulse.org is where you can download free versions of that Post form in order to get those to the doctor and get those completed and signed. Here at Alzheimer's San Diego, our social workers can provide you with, we keep a good library of resource lists and tip sheets on some topics that are relevant to what we've been talking about here today. Advanced care planning, legal issues, brain and body donation information, counseling, end-of-life care, and support, lists of local hospice providers. Palliative providers are, I believe, indicated on that list as well. Physicians from a variety of different specialties, and that checklist that I mentioned before, what to do following a death. Lots of other topics as well, but those are the ones that are kind of relevant to what we're talking about here. If you want any of those tip sheets or resources, just fill out that form that Ellen and Mona have been sending out, and a member of our team will send that to you. A few other resources I want to make sure that you are aware of. Here in San Diego County, we have a really robust environment, a community of people who are working to make death a topic that people are more comfortable talking about, keeping it sort of closer to us in our daily lives. Death Cafe, I'm not sure that they're meeting right now during the pandemic, but they might be having virtual visits. I'm not sure, but we have several death cafes that meet regularly here in San Diego County. If you've not heard of one, I'm just going to read this short description for you. They're terrific. I've been to many of them. At death cafes, people come together in a relaxed, safe setting to discuss life, death, and dying while making the most of our finite lives. It's not therapy. It's not a grief group. It's simply a welcoming forum for discussion. Death Cafe is built on the premise that many people want to talk about death, but don't feel comfortable addressing it with family and friends. The safe, secure, confidential atmosphere of Death Cafe fosters dialogue among individuals who share a curiosity and a desire to explore the end of life and its surrounding issues. And it's a beautiful description of what happens in a Death Cafe, and my thanks to Karen Van Dyke for that language that I pulled from her website. She runs a Death Cafe here. There are many of them here in San Diego County, and I strongly recommend it if you don't have a source of support and conversation in your life. They can be a really nice outlet for anyone, adults, of course. The Hemlock Society of San Diego, their website is provided for you here. This is an organization that's been around for decades here in San Diego County. They do a variety of really interesting education programming. They have public meetings several times a year. I think it's about every other month or so. They show films and have discussion groups. They do an extensive amount of advocacy, bringing like-minded people together who want to talk about their end-of-life choices and can provide you with resource information as well, a really nice resource. And the San Diego Coalition for Improving End-of-Life Care. This is a group of professionals, but it is open to anyone. Their goal is to educate and raise awareness within here in San Diego County about end-of-life issues to provide resources to help people make informed choices. Very active here in our county and really focused on helping people doing that important advanced care planning so that they know what they want and don't want at the end of their life. So, of course, we here at Alzheimer's San Diego want to be a resource to you. We have our team of dementia experts. Ellen is just one of a terrific team of our clinical services team of social workers and other professionals who are here to answer questions, connect you to resources, help you find your support group, another class that might be helpful, connect you to a volunteer or a respite program to give you a break, help you find that hospice or palliative care provider, or kind of coach you through language for talking about it with a doctor or family members who might be resistant. For example, lots of different ways that we can help you and lots of different ways that you can reach us. We have a lot of great information on our website. You can call us, email us, live chat right from our website, or fill out that request form that's been going out in the chat. Again, just let us know the best way to reach you, and a member of our team will follow up. We do have a couple of upcoming education programs I want to bring to your attention. Throughout the program here today, I've been talking about home care and memory care and skilled nursing facilities. We have a couple of classes about those care settings where you can learn more. March 23rd, that's next Tuesday, we do our program on at-home care options and as well as community-based services, adult day programs, for example, PACE, for example. And then the following week, we'll do a program on residential placement options, boarding cares, assisted living, memory care, skilled nursing. What is all that stuff? And how do you find it and access it? If you are interested, we have a really neat program that we'll be doing on Friday, April 2nd. This is an improv workshop for family caregivers we call it living in the moment, kind of learning to think on your feet and be creative when the person you care for is confused, disoriented, saying things that are sort of not making sense, instead of using improv as a tool for learning how to respond rather than argue and react and confront and correct and do all those things that we normally do. So this is kind of a unique program. It'll be fun, but we use play, we use games. It is definitely something different. If you're interested, all these classes and all of our upcoming programs are available on our website, alsd.org/classes. So that is the end of our time here today. I thank you all so much for your great questions, for all of your sharing in the chat. It moves me deeply. I really appreciate you being here today, sharing with us, being willing to explore and engage on these tough topics and questions. I hope that it helps mitigate some of the fear and uncertainty around this. It doesn't make it better in the least, and I'm I'm deeply sorry about that. But I hope that it helps make it a little more kind of manageable, and kind of know a little bit more about your next steps and where to go for more help when you need it. If you have a moment, we'd love your feedback. When this webinar ends, you'll get a link, you'll get directed to a survey. We'd love your feedback. If there's things we can do differently in this program, if there's other resources or information you need, please feel free. It's an anonymous survey. We love your suggestions and feedback. We need them, and I rely on them heavily for program development. So please feel free We will be emailing out this afternoon a copy of all these slides with all this information, as well as a link to our webinar library where you'll find a recording of this program within another couple of days. It'll be available there. So with that, I'll wrap us up. I thank you, Mona, for helping out today in the chat and with tech support. And Ellen, my deepest thanks to you for being available to help answer questions and support me in this program today. And my thanks to all of you again for coming and your courage and your love and everything that you're putting into your caregiving. It's not lost on us. So thank you.